Hi everyone, this is Nick here with the Ontario Network. If folks on the chat there can hear me, if you could just say hi. Great, thank you. Hopefully you can all hear us okay. So welcome to the webinar. This is the webinar. Some of you may have been here on Monday when we had terrible tech issues. We very much apologize for that. And hopefully it all goes smoothly today. Just to let you know, we are recording this webinar, and we will be making that recording available later. So if you need to step out early, or if you have colleagues that would like to see this, we'll have that recording available. So this webinar is about engaging people who use drugs to build organizational capacity. I'm just going to walk you through the platform that we're using first. So if you look in the top right corner here, you will see who is on the call. If you would like to start a private chat with any of those people or any of us, so I'm facilitating along with Peter and Ashley. I'll introduce them in a minute, but we have in the background Christian and Kim from OHRN, so you can always send them a private message. If you would like to contribute to the discussion in the bottom left, that's where you can ask any questions, provide some comments. Occasionally we will have a couple of polls, we'll bring those up separately, and you can also download some resources in the bottom right corner. So there's some really good resources there, including the slide deck that we're using, and you can download those at any time. So we also just want to acknowledge that the work that the Ontario Harm Reduction Network does takes place across Ontario on the traditional Indigenous land of Turtle Island. Our office, though, is located in what is now known as Toronto on the traditional territories of the Anishinaabe, Huron-Wendat, Haudenosaunee, and Mississaugas of the Credit River, where the Dish with One Spoon Treaty binds all allied nations and settlers to peaceably share and care for the resources around the Great Lakes. Today, Toronto is still home to many Indigenous peoples, and we are grateful to have the opportunity to meet and work on this territory. We wish to express gratitude to Mother Earth and for the resources we're using, and honor all Indigenous peoples who have been living on the land since time immemorial. I also just want to recognize recent events in Canada and how what we're talking about today is particularly important as we're engaging with Indigenous folks. There's a whole other layer there that we need to be thinking about. So as we're talking today about how we're engaging people who use drugs, we also want to think about how that applies in the context around Indigenous folks as well. So I'd like to let you think a bit about that when we finish today. So the Ontario Harm Reduction Network supports harm reduction efforts in Ontario by providing training and networking opportunities, and we're doing some consultations with service providers. Our primary focus around HIV/AIDS organizations, community health centers, and public health units. And we're funded by the Ontario Ministry of Health. And our vision is really that all people who use drugs are treated with dignity and respect, free of judgment, and receive effective care and support when accessing services in Ontario. And we do that, as I said, by providing training, education, and networking opportunities. Before I move on to talk about the webinar, then I would like to just also introduce Peter and Ashley. So in all of our work at the Ontario Harm Reduction Network, we try to live by values of engaging people who use drugs. All our staff are people that either use drugs or have used drugs, and we also then bring in people with lived experience, which is what we're going to talk about today as well, to help tell the stories, help talk about the technical information and compare and contrast that with the stories as well. So Peter, I've known you for quite a while now. Do you want to just give a little intro?
Sure, Nick. So I'm Peter Leslie. I grew up in Scarborough in the 1960s, but I found myself using drugs when I was a teenager, then ended up going to many rehabs, 11, and I found my real niche in this world when I was homeless, and I was introduced to harm reduction in 2006 at a workshop, and that's when my harm reduction journey began, and I've been working in this field since then. And I was housed a handful of months after that first.
And what kind of different roles have you had in terms of being hired because of your experiences around drug use?
Initially, I was involved in actually overdose prevention workshops with the Toronto Harm Reduction Task Force, and then I became an outreach worker, a harm reduction outreach worker with Queen West Community Health Center, and that was for 18 months. And then I got involved with the Works, Toronto Public Health, as a harm reduction peer worker in their 277 Victoria needle exchange. Sat on a couple of city committees, involved with policy work, but I really like the frontline work. It's where it's passion for me. And I worked in Moss Park when we started there, and then I've worked in 2 other overdose prevention centers, or CTSs.
A variety of different roles. And then also Ashley, I'd like to introduce Ashley Smoke. So do you want to just say a few words?
I'm coming from Peel Region. I work as a harm reduction outreach worker currently, as well as I sit on various committees and drug strategies. I also came to this work from my schooling. I did community and justice service worker, and yeah.
So we're going to, Ashley, Peter, and I will come back and talk about some of their experiences and insights. I've only more recently met Ashley, but I can tell you she's a wealth of information, has so many good insights, and I'd like you to hear lots from them. As we go throughout the presentation and the webinar today, please just ask questions in the chat box there. We don't have there's too many participants to have you all on audio. So if you would like to communicate, do that through the chat. Ask questions as we go. Kim and Christian are in the background there, so they'll keep an eye on the questions. And you can direct them either to us or directly to Ashley or Peter or myself. So this webinar is really a basic introduction to a very complex topic, and we'll explore some of those difficulties and challenges, but also all the really good opportunities. But as I said, this is really a basic introduction. We have 90 minutes today, so we're not going to go too deep into things. We're really going to also just highlight some existing resources. There's some really good work that's already been done around this. We work with a number of agencies around the province that are already doing really good engagement with people who use drugs from all across. And you heard both Ashley and Peter have different types of roles in terms of advising or maybe helping with research or direct service provision. There's lots of different ways that people can get involved. But we don't need to be recreating the wheel. So in that resources potted gang, you'll find some really good resources, and we've basically borrowed stuff and highlighted some key things from those resources today. So we were really overwhelmed though with the response to these webinars. We had well over 100 people registering for them. And we think that this is actually a piece of work that over the next year, as the Ontario Harm Reduction Network, will probably be developing this further and exploring this and having either other webinars, maybe creating some videos, exploring this topic further. So we will be talking about, we've been using the people who use drugs, we've been using peers terminology. We'll explore that, what terminology we could or should be using. We'll talk about the top reasons why we could involve people who use drugs or should be. There's some stuff around basic engagement principles. So if you're going to be involving people who use drugs, what are some key things to be thinking about and how to do that? Some examples and then some practical tips as well. And then we'll leave a little time for discussion at the end. So in order to build, as I said, we provide these networking and learning opportunities, and we value diversity and comparing and contrasting experiences. So I know there are some folks on the line that have doing this and probably know this topic better than us. And then there are some folks that this is really new concept. So we want to hear from all of you. So again, please contribute to the chat there. I think it's important to recognize that as we're learning, we change and we grow, and it's okay today if you're using language that might you come to realize is stigmatizing later on. So don't be afraid just to use whatever language or ask any questions. There's no such thing as a stupid question. So please do that. Recognizing that this is a public platform, obviously confidentiality, we can't guarantee that, but we ask that you know, anything that, particularly if Peter and Ashley are sharing stories, you can relay some of those, but maybe maintain their confidentiality as best you can if you're sort of telling these stories to coworkers later on. Not going to go through all of these, but you know, learning is a process. We're constantly learning, and this is just the start of a conversation for many of you today. So I encourage you to participate in the chat as much as you can. We just wanted to get a sense of who else is on the call, so I'm going to pull up a poll here. And recognizing that you may come from different regions, we're using the old LIN system here, really, or soon to be old LIN system. So just let us know where in the province you are. All right, so a big chunk of folks from Toronto Central, and then we've got a spattering throughout the rest of the province. All right. Okay, so we've got some good representation from around the province. And then we'd also just like to get a sense of what sector are you working in? So these are broad sectors. Obviously, people may cross things. This isn't all encompassing. I think you may be able to select more than one, I don't recall. And if you are selecting other, maybe just type into the discussion pods, sort of where are you working? What kind of center or agency are you at? So it's nice to see, well, we've got a lot of folks already working in harm reduction, so I'll be curious to see how many of you are already doing good work around engaging with people who use drugs. I would like to think a lot of you are. But even we know that there are programs around the province, maybe in needle exchanges, where you might have a nurse, for example, handing out needles who has really no understanding or experience, and this is not to fault them or the agency. It's sometimes a matter of resources or just not thinking about how we could be doing things better. So even within harm reduction programming, we find not always good involvement of people who use drugs. We've got some mental health folks. Okay. All right. So a real sort of cross-section of folks too. Some housing, primary care person, ASOs, that's aid service organizations. So it's a real mixture of things too. Okay. Nice to see the variety of folks on the call. So before we get into the meat of the webinar, I think it is really important to reflect on the context in which we're all working. And that is the context of criminalization and prohibition. We say that it is not okay to use drugs, and you will be punished if you do that. Or I should say, if you use certain drugs. Has criminalization impacted you, or could you talk about how you guys have seen criminalization impact people you work with?
Go ahead.
I mean, criminalization impacts all of us every day.
As drug users, as people who use drugs.
Yeah, for me personally, I've had an issue with criminalization in regards to sex work, with like, not necessarily me being criminalized because of the new laws, but like clients and security managers, whatever you want to call them. It's made working as a sex worker a lot harder. and a lot scarier. But as far as when it comes to drugs, I think even when I go to meetings and stuff, I'm hearing police say like we can't arrest the drugs off the streets. Like we can't do it anymore. They were actually saying like decriminalization would probably be a good way to address the the problems we're having with drugs in today's society. So it's interesting to hear like even the enforcement starting to change their mind and go towards decriminalization.
For myself, I remember growing up in high school in the 70s, and I remember the first time I encountered the police. I was smoking hash in the schoolyard. I think it was on a weekend or something, and the police took our hash and were very aggressive with us. But ever since that time, it's been I've just learned that that it's not just the authorities and the police, but it's also the media. We're portrayed as evil, damaged, criminal, and you know when you grow up with that shame and stigma, it's embedded in you. And I'm white, male, have a good education, and so I've been with many people who are obviously more criminalized than me and more vilified and targeted and surveilled. Yeah.
Yeah, so this concept, we've grown up in a society that teaches us that people who use drugs are bad. So this shapes the language that we're using, and it shapes our attitudes and approaches. And I think we have designed a lot of the programs theoretically to help drug users, but it's very top down.
It's based on whoever wrote them's idea of drug use and
right. And what the end goals should be for drug users, and we patronize and pathologize people. So I think it's really important to remember that as institutions, as individual workers, there's a lot of stigma and stereotypes and attitudes and values. And then that can also be internalized, and that makes it very hard for people who use drugs to be open and honest. So we're very fortunate that Ashley and Peter are taking a huge risk in terms of outing themselves around this. And when you go into those committee rooms, you're really putting yourself out there, right?
Yeah, especially when you go there and the police are wearing their uniforms. Like I remember going into one big meeting and everyone there was like a social worker and was dressed nice, and I was very intimidated. And then in walks this big, huge police officer with a bulletproof vest, and he sat right beside me. And I smelled like weed, and I don't know. I was just like, oh.
And I think this is so important, and we'll come back and touch on this too, but the power dynamics at work. So if we're going to be engaging people who use drugs, those power dynamics in terms of meetings, how we're running things, and if we're trying to get good, honest information from people, we really have to be mindful of these power dynamics, which are rooted in criminalization. Okay. The other thing I want to just touch on too is that historically, I think what we consider now standard harm reduction programs and services, so for example, needle exchange programs or distribution of crack pipes or nowadays meth pipes, drug checking services where we're actually testing drugs, and now more recently actual drug consumption sites or overdose prevention sites. All of these were originally driven by people who use drugs. It was people who used drugs not getting the attention and the support that they needed and taking that initiative, and it was often by breaking rules, stepping outside the norms, challenging that status quo is what got them going. The picture you see there, Peter, you probably recognize that picture from the trailer.
Yes, that's from the summer of 2017 when we pitched a tent and then set up a trailer a few months later in Moss Park.
In Toronto, and what was the impetus for, what was the reason for that?
There was, I believe, 7 fatal overdoses the week before we opened our services in the park, and the 4 SIS or supervised injection sites in Toronto that had been earmarked for funding were given the funding in the spring, and they still yet were not open. So it was out of grief and anger and sadness that we opened up the Moss Park experience, if you will.
And nothing about us without us. It was all
Yes.
driven by people who use drugs and frontline harm reduction workers.
And thank God you guys did that, because
Ugh.
if you guys never did that, I don't know, like, if us in Peel would be having the same conversations we're having.
I think I got to spend some time down there myself too, and what was really interesting too was there were a lot of very interested nurses that wanted to help, and they were very genuinely interested in helping, but many of these nurses had never ever once witnessed anyone inject drugs. There were some doctors that wanted to come and help out too, but they had no understanding of the language to use, the culture, or even how to effectively respond to overdoses. Drug users had been responding to overdoses for years before this and knew what to do. And it was really interesting to see when the involvement of the nurses and how much they learned from people who use drugs. The reason that site became so successful within the first 3 months, reversing 90 overdoses, was because it was driven and rooted in the experiences and expertise of people who use drugs. So I think it's really important. Now in 2020, we have a lot of programs where we're just doing it. It's become second nature in terms of the programs that maybe we're running through health units or community-based agencies. But sometimes we forget to actually think about what drove this in the first place, and we're not actually always paying attention to the people we're trying to best serve. And so then you start seeing policies and programs and services that actually are no longer as effective, right? Because they've forgotten to think about the end user. This is a document from the Canadian HIV/AIDS Legal Society, so you can click on that there or download it in the pod, but I just took a quote from that report, and it talks about how most of the responses to drug-related overdose and drug-related crime, family breakdown, drug treatment, unemployment, these days have often been developed in isolation to people who use illicit drugs, and a lot of that is because we leave them out because of these, coming back to stigma, this mistaken belief that we think we know what's best, or that drug users are just disinterested or just incapable of having meaningful dialogue and don't know what they're doing. It comes back to that idea of pathologizing and patronizing people. So we really, again, come back to the idea of we really need people who use drugs at the center of all of our work. So it's not just in the service delivery, but in the planning and the design of those programs too. So can you talk about some of your experiences, I think, at where you first got connected in or saw services that talked to you?
Well, I started doing this work when I was in school. So I remember doing this needs assessment for sex workers, and there were no services for sex workers. And when we started unpacking some of that, there were no services for drug users. Like there was methadone and whatnot, but those are not, I think those are more abstinence oriented. So I realized that in Peel there was really no services for us, and I think that through advocating and working with people who utilize the services, we started a Peel harm reduction network, and through that we discovered that there are services. We just have to figure them out and refer people to them. And I realized that there was a lot more than I thought. And through meeting people, other service users, I discovered that we all have something in common, and maybe we should be used to be employed there instead of some of the workers that are employed there. But
So let's just pause for a second, pull up another poll. If we're actually going to be engaging people who use drugs in our organizations, and we're talking about people who are actively using drugs, so type away. This is anonymous here, so you can type in the box here. So just type in what you think might be some of the perceived concerns or challenges with having people who actively use drugs working in organizations. And again, this is anonymous, so no one can see what you're saying. And we'll come back and talk about some of these in a little bit. I'm not going to address them all right now, but just we'll make a note of some of these and then come back.
I just want to make a note that I use drugs and I'm very reliable and dependable.
So things like what about using drugs, safety? They would be distracted. One there around the opinions of other staff and stigma. I think that's an interesting one.
That's a hard one to deal with.
Openly breaking policies, triggers, and traumas. Something we can note from.
Using your own brain.
Yeah. And safety of themselves and others. Conflicting internal organizational beliefs, and it appears to explore that one a little bit more. Mind altered, in your, I want to touch on that one quickly, but is using drugs always about altering your mind, or?
I think it depends on what you're using and the purpose of that use. So like, the whole drug set and steady thing, and people use different drugs for different reasons. And I'm not saying one reason is more valid or credible than the next, but it's appropriateness of what people choose to use. But also, if we have duties and we have work to perform, we're expected to perform that work, and I understand that and I embrace that.
But for some people these days, particularly if they have more of a physical dependency on the drug, they may actually have to use that drug and able to be able to perform. It's not about getting high or fucked up or mind altered.
For me, it's more about feeling normal. Like I don't really have that cerebral effect.
I'm just taking a quick look through this. We will come back and talk on some of these specifically, but one of the things I haven't seen anyone mention there, and I think this is much more of a concern than it was maybe 5 years ago, but is around overdose. We now have people, you may be inviting people into meetings or on shift who have to use, and now, again, coming back to prohibition, it has created such a toxic supply. The unregulated drug supply nowadays is so toxic because of prohibition. We now, when we're preparing our meetings or having gatherings, particularly with folks from out of town, we have to make sure that we have overdose response plans in place. We have to do bathroom checks. People may be going on the lunch break and using in the bathroom just so that they can get through that meeting. So these are the reality of this kind of work in 2020.
And that's important, the bathroom checks and stuff like that. We don't have that because of building codes and stuff. So it was kind of nice to see that people watch out for each other, and I think that's important.
And I'd like to mention that a lot of public spaces and health centers, they have safe disposal boxes or units in the washrooms, and a lot of these places are also handing out kits, harm reduction supplies. So I just want to say, what kind of message is that sending? That, well, we're anticipating people using, so we want to keep them safe. We want to make sure that the syringes or anything else is disposed of. But it's also having to use in the toilet, which is it can be very unhygienic and a very solitary experience, if I can say that too. So I think maybe appropriate places to use makes a little more sense.
Okay. Again, we'll come back to talk about some of these, and these will come out in the conversation. There was, I think, one more poll here that I wanted to bring up, and that one. What then might be some of the advantages of having people who use drugs involved in the design and delivery of services? And again, this is anonymous. Relatability, first-hand knowledge.
I liked what someone said in the focus group. Like it was like I forget what words they used, but like pretty much street cred.
Street cred. Right.
Like.
Well, I think you talked when we've had conversations. You talked about how you many of the clients in the organization where you're working wouldn't be there without you.
Oh no! Well, or someone.
Right.
The peers.
Someone, right.
Yeah. Yeah, no, the clients definitely, there would be no clients without us peers to bring them in. And it's those relationships that, like the trust that's already built, why the clients come to us, right? It's really hard to bring a worker along with you and like make the introduction and like have the client and the worker have that same rapport. It's not the same as when you have someone who's been there and experienced those things dealing with the client.
I think when you can just have like a natural kind of laid back conversation with people around sharing stories around drug use and best practices, evidence-based stuff, which are really terminology for just making things smoother.
Mm-hmm.
Yeah.
There was one I just saw here which I wanted to just touch on quickly, and I'm trying to see it. It had to do with, where was it? Understanding the system, I think. And I would say maybe in that, understanding, I think, what works, but more importantly, maybe what's not working in terms of services. Although we will come back to talk about that in a little bit, but there's also, I think, for some folks who use drugs, maybe a lack of understanding of the system and how things work, and particularly in terms of programs and policies and funding and organizational objectives and restrictions. And that comes back to a key principle we'll talk about, which is explaining to folks why things are the way they are. Doesn't mean they shouldn't be challenged and we shouldn't be changing the way we do things, but explaining to folks, how meetings run maybe, or why services are restricted the way they are. So that helps people who use drugs also integrate better into agencies or understand the system from that point of view. Okay. So buy-in, legitimacy, comfort for service users, right? Personal insights, they know what they like. Okay. Democratic, make systems. Oh, where did it disappear? It disappeared.
Show their cards to they serve.
Make systems show their cards to those they serve. Yeah, access to folks that may not otherwise access formalized services. So.
And that's a big one. Like a lot of our clients wouldn't access services. Like they wouldn't go to a needle exchange. They would probably just buy the needles. Right. Because they've heard of our service from us, they're more willing to call.
Okay. So we'll come back and again, some of these are going to come out when we get into these principles and some of the principles and some of the reasons why. So this, if you click on the blue link there again, or in the resources download, this is a really good resource from BC, but they talk about the promoting of peer engagement, and we'll talk about what we mean by peers in a minute. And this is coming from BC, so they have health authorities there, but they talk about how peer engagement can improve the involvement and uptake of peers' voices within health services planning and policy development. And they talk about these engagement principles, which we're going to come and talk about in a bit, in terms of fostering best practices and meaningful inclusion. And that then promotes these positive relationships and capacity building. So we're not all, it's not also just about building organizational capacity, but there's a two-way flow here, and we're building the capacity of people who use drugs to then do the work effectively and help organizations do their own capacity building. So it's a two-way street here if you're doing it well.
Mm-hmm.
You talked about recently onboarding at one of your jobs and being introduced to everyone, which had never happened before.
Yeah, oddly enough, yes. I mean, I've worked at two other community health centers before I started at Regent Park Health Center a couple of months ago, and I thought it was, I was getting ready to ask my coordinator if I could just have a tour of the building and meet other people. And she made it quite clear that, oh, that's where we do that. That's standard operating procedure. And I thought, well, I think that was remarkable. It was like, it was.
That wasn't something that had happened before.
Not for myself. And
Right.
I worked, my first community health center I worked at was 2007. It was a great place. But there seemed to be this upstairs, downstairs sort of mentality, culture, sorry, not mentality. Primary care and the counseling was upstairs, and the so-called urban health team was downstairs. And I just felt there was a division, kind of us and them, othering in the building. And I joined their board of directors to try and help that for 6 years. And there was some moderate improvement, but it still exists. I think it's to do with the way healthcare is delivered and structured around the professionalization of healthcare, which is necessary.
So we'll look at the principles of engagement in a bit, but just wanted to reflect a bit too around the terminology that we're using here. So we're talking about peer engagement, but what does that actually mean? What are some other language that you may or titles that you've been used? Actually, before we do that, let me just pull up another poll. So for folks on the phone, oh, sorry, that is not it. I don't have the poll here. It's not actually a poll, that's why. Sorry. It's okay. Maybe just before we come back to talk about that, if you could type in the discussion box, folks on the webinar, like what might be the advantages of calling people peers, or what are the pros and cons of using that language? So I think historically, we've seen it much more in the mental health sphere around peer engagement, and that often means, you know, people that have something in common, right? Peers. I know I got my start in harm reduction as a peer in the rave scene. I was someone going to raves and doing drugs and dancing all night and wanting to connect with other folks. And there was a group here in Toronto called the Toronto Raver Info Project. These days it's now known as the TRIP Project. And it was peer-based, so it was literally other ravers connecting with other ravers and training them, and then going back into those events and connecting with other folks and training them and educating them and responding to overdoses. But it was peer-based. It would have looked very odd to have a 45-year-old nurse at the rave. Just wouldn't be able to connect in quite the same way that when we were in our 20s we could connect with each other. So we talk about peer engagement, but what are the pros and cons there of using that language? So it outs people, right? So immediately we're saying, yeah, you have this thing about you.
Especially in harm reduction, like if you work in harm reduction and you're a peer, people assume you're a drug user.
Right. Mm-hmm. We see other peer roles where the Ontario Harm Reduction Network is housed. We're in an HIV housing organization, and we have peers there. Automatically, people then know that that person has HIV. Then from a client perspective, they may feel equal. Like they know that they have something in common with that staff person. Lisa here saying trust is not an imbalance of power, so that I guess when you're coming in and you're working with a peer worker, you understand again this common thing that you have. It's inclusive, equality. con. It suggests a panacea of experience and can.
Yes.
Sorry,
Mr. Chris.
I've lost the chat there. Tokenizes people, right? It outs people. It's a bit vague, creates a false sense of familiarity. Okay. So what's some other language then that you've seen or is being used these days?
Well, I don't know about what's being used, but I know that like me, I'm a harm reduction outreach worker, but they call me a peer outreach worker. So like I think you don't need to add peer in there. Like we are what we are. We
Right.
do other things. Like coordinators, like in a sense, like I've done coordinator work, but not being called a coordinator because I'm a peer or because I use drugs. So like there are issues with
So
calling
it's
people
David here
peers.
saying that the peer nomenclature is more for organizations to feel good about
Their self-perceived inclusivity.
their self-perceived inclusivity.
For sure.
Yeah.
And many funding proposals,
Yeah.
grants have this language, and it's actually a requirement for
It's like
some of the.
a new
funders.
like hip term. Like I don't know how to explain it, but yeah, it's like the new.
But it's loaded to some degree.
Mhm.
It's associated with more of with your lived experience than, frankly, with your skills.
Mm-hmm.
Yeah.
Emma here is saying, I've heard from peers that having that title prevents them from moving up in the agency.
Completely.
Certainly.
I should have been way higher up in my agency than I am now.
It can be a bit, it has in some organizations become a bit of an out to be able to deliver services at a cheaper rate or not employing people but having people on contracts.
Yeah,
Not
And
paying them equitably.
that's
Yeah.
all of that has happened to me.
And I think people need a choice as to whether they want to out themselves or not, too. Especially people who have a history of incarceration. Maybe they're hesitant to be labeled. And but I mean, some people. I mean, I felt it incumbent upon myself. I thought it was necessary for me to out myself. Because I'm a person that has a great deal of privilege, and I thought I had to maybe use that privilege for a good thing.
And it helps in terms of destigmatizing things
Yeah.
when we start outing ourselves and
It's
start
kind of
normalizing.
therapeutic too.
Yep.
So other terms, so as we go through the rest of the webinar here, you might hear us using terms like peer, being mindful that I often use that word in quote marks. We may be talking about people with lived or living experience. Often I find when it comes to drug use, we talk about people with lived experience, but in many programs, that is someone who is now not using drugs, or they're in recovery, they're abstinence-based because they've gone through their drug use, and it comes back to this idea of drugs are bad and you shouldn't be doing them. So I see a lot of advisory committees where the person representing drug users is now someone that's abstinent. So increasingly though, I'm seeing people with living experience that can sometimes imply that they still use. We might use the acronym PWUD, or a person who uses drugs. That's people-centered language, right, instead of just drug user. And I still use the term drug user, but we try to use more people-centered language. Increasingly, though, in harm reduction programs, we're just literally talking about their harm reduction workers or overdose prevention workers. Okay. All right.
Animator, that was the word.
Oh yes.
Yes.
Animator. Someone
Animator.
had used that. That was you. Yes.
Yeah.
Jennifer Broad there saying, I hate being referred to as an acronym. I think that's a good point, Jennifer. It becomes all-encompassing. That's all you are. I think for the sake of brevity, sometimes we use that kind of stuff, but I totally get that point, Jennifer. So we want to draw your attention to this resource, and this is a resource that was primarily developed and written by Cheryl White and Rafi Balian. Do you want to just talk about Rafi for a second?
Oh,
And
yes,
why he was so critical to all of this.
I met Rafi shortly after I found harm reduction, and we, as soon as we each found out we were both big soccer fans, we became much closer, and we truly became friends. But Rafi Valian started the harm reduction program at South Riverdale Community Health Center back in, I think, 1998. So, close to a decade before I found harm reduction. And Rafi was known internationally for a lot of the work he's done.
And he was someone, though, that used drugs.
Certainly.
And was out
Yes.
about that. And
Yes.
we're talking about injection drugs.
Yes, Rafi was a expert injection drug user, I'd have to say. Yes, and was he understood the technicalities around injection drug use too, which is I have injected drugs. It's just I'm not a regular injection drug user, certainly at present, but I too am familiar with it. But I would defer to Rafi certainly in that capacity.
But he was so eloquent in terms of his understanding of why it was so important to center everything around people who use drugs.
Yes,
and could explain that.
And South Riverdale and Counterfeit, which was the harm reduction program there, and now Keep 6, which is the supervised injection site there. Rafi made it quite clear to management that the reason why these programs will succeed is to have people with lived experience. And Rafi was part of the hiring and promoting of many people who still work at South Riverdale today. And also Rafi was the first person to bring naloxone into the country. I have to give him that plug.
So this is a resource here. I mean, and this is back, I think, in 2008. Maybe this was written. I can't remember now. Maybe before that. This is your go-to resource for a lot of this stuff right now. So we're doing a quick 90-minute webinar on this right now, but go download this and read this book. There's all sorts of good stuff in here, from some of the guiding principles to things you need to be thinking about in terms of policy development, training, supervision. So download that one for sure. These are then the top reasons that Rafi and Cheryl came up with in terms of hiring people who use drugs, and we've talked a bit about some of these already, but the first thing it does, it demonstrates your commitment to working with people who use drugs. They see themselves reflected in that agency. Mm-hmm. So, I think that was one of the reasons you maybe first started getting connected, was that you started seeing other folks.
Well, I started through school.
Right.
I had a student placement, and I told my teacher, like, I'm a sex working drug addict. Like, I have all this life experience. And I don't, like, I got high honors because of my life experience in school. Like, so I was like, I do so well in school. I would hate to not have a placement. And so she was like, go to this person, and she sent me to where I work now, and I met a woman there, Natalie, and she was just like me, but open about it. So.
And you hadn't experienced that previously?
I had not. I had not met anyone, especially not in social services or in the community doing like that kind of work. I've never met someone that was open about their drug use. I don't even think like a teacher or anything. So I was like, wow, like I think I could do this, even though I have all this shit in my closet.
Mm-hmm.
I can do this work. So I continued to do it, and I excelled.
So then Natalie, who was an employee there, became a role model for you, which is their second point here. Mm-hmm. And now you're sitting at committees and helping facilitate.
I'm where she was when she had me.
Yeah. Then another reason is in terms of people who use drugs are most often the most effective in terms of getting messages out to other people who use drugs.
Certainly. I mean, to be honest, I came away with more questions than answers from my first harm reduction encounter, but it was I was homeless at the time, and it was a buddy of mine, Bruce, who I used to smoke crack with when I was homeless, that brought me to my first harm reduction meeting experience. But I also have to be cognizant if I'm on the street and I meet somebody that I'm a very sociable person, so I talk and I visit a lot of people, but also I have to realize that not everybody wants to be known on the street too. So I have to watch it. Yeah. So these are boundaries that we kind of pick up and learn as we go along.
We bring the clients in, right? So, and I think it's also important, like we can be real with them. Like as a peer, I find like I can be more real with what I'm trying to relay in my information as opposed to someone else. Like
They can be well-intentioned and book study
Yeah.
and all of this, and probably have a lot of knowledge too, but sometimes it's just how you learn how to relate to people and just the
Yeah.
language to use.
Yeah.
You also just mentioned we bring clients in, but it's also sometimes about actually going out. We know we're not always going to bring everyone into agencies.
Yeah.
So
You have to meet
connection
them.
to communities, know where to find people.
Yeah, that's a big one, is where to find people, because sometimes we're not necessarily, drug users are not necessarily out there. So I think you have to be able to go to where they are.
So then it's also it's a two-way street of information, but also allowing agencies, again, this other point here around just valuable knowledge and practices and understanding what the issues are within those target populations. And I think even increasingly, this is so important right now, or it's just becoming more and more evident right now. Some of you may be aware there's been some media attention just in the last week or two around some of the overdoses that have been happening in Ontario, and the fact that the drug supply now is being contaminated with benzodiazepine type drugs. This is a new thing, and many workers are not sure what's happening or how to respond or how people are presenting. But you talk to people who use drugs or some of the frontline harm reduction workers, this has actually been going on for months already.
Oh yeah.
Right? And they've already know how to be responding to these overdoses. But just recently, last week, we saw some mixed messaging in media and from some public health folks or police around naloxone and how it doesn't work on these overdoses, which is technically not true.
Yeah.
It is still working, it's just people are presenting differently.
It's just they're becoming like they're breathing, but they might not be waking up.
Right.
Sedation.
Yeah.
Sedation. But this again is something that people who use drugs could have been telling folks for a long time, but for some of the professionals, this is suddenly a new thing. And this is why, again, it's so important to have relationships and being informed by people who use drugs right now. Okay. Just having a job gives people a sense of purpose. So, I think you've talked about this previously around how your connection to starting to do things in harm reduction changed things for you.
I think the shame that I carried from over decades, and also I was a paramedic for close to 20 years, and had gone to rehab a few times when I was working in EMS, and so I was like, I had this kind of closeted life that kind of trickled out of the closet, out of my control. But I became homeless after my EMS years, and then had a cancer diagnosis. So when I was homeless, I was very depressed and despairing, and had just really given up on myself. Had given up on treatment. Had given up on finding a life again, if you will. So it was that afternoon at that workshop that my buddy Bruce took me to, changed my life. And it didn't change it overnight, but it was an epiphany of sorts.
And you've learned different skills along the way now that you can apply.
Yeah, I mean, I'm very passionate about harm reduction, and more so passionate about working with people who are who are like homeless, people who are in the shelter system, and people who are really hard done by, frankly. I dig a little deeper at that end of the trench.
Okay, I'm noticing the time, so we had lots of good discussion here, but I want to move us along. So this is another resource. This comes from BC again, and these are some of the engagement principles that they think about. And I won't dig too deep into each of these because we've already been talking about some of this, but the first one is obviously people who use drugs as experts, right? Really understanding this. I've got an example of that and another example of that in a minute. Equity, diversity, transparency, accountability, shared decision making, and increased capacity. So I'll touch on some of these, but this manual here will explore each of those much more deeply. So again, that's available for download in the pod there. We've talked about this already, but just as an, the first one in terms of being experts, but this is just a picture of a injection kit that I went into an agency recently and just said, can I just get one of your injection kits? And when I opened it up, I don't know if folks in the chat there can tell me what might be wrong with this kit or what might be the problems, and it's okay if you don't know. But this is just a very obvious example to me of when I asked them, because there are real problems with this kit and how that's been put together. When I asked the workers, who put this stuff together, it was an admin person within the agency. And if you knew someone who injected drugs, do you think that's what the kit would look like?
No.
And what's wrong with the kit?
Well, there's only 3 needles, and there's 5 cookers, and about 100 cottons.
Right.
3 straps. Like
the ratios are just
yeah,
no sense.
it should be 1 for 1, if anything.
Yeah. So Stephanie there and Allison are talking about really it should be 1-to-1 ratios, and it doesn't make sense. So this was well intentioned, but the people just had no clue what they're doing. And I think the impact of this might be a small example, but the impact of this is first, the supplies don't make any sense. You end up with some stuff that's wasted. But I think a more critical problem with this is that if I'm someone who injects drugs and I get given a kit like this, you as a worker or as an agency are going to lose any credibility.
Mm-hmm.
I'm going to see this and say, you have no idea what you're talking about. So again, why not have someone who uses drugs put this stuff together?
At our drop-in, we're going to pay women to do the kits for us.
Right.
Like,
Yep.
Now that doesn't mean to say there isn't some training that they may need.
Yeah.
We may need to train people who use drugs. Don't always know everything, so it's a two-way street. We're training them in terms of how to do this and what to put together, but again, working together. Right? Equity is another principle here. So again, using again, this comes back to the idea of, I think, the power dynamics at work in the relationships. So trying to really level the playing field when we're working with people who use drugs and recognizing those power imbalances, particularly around decision making. Very often it's top down when we're making decisions, and we need to do a much better job at giving people who use drugs some kind of context in terms of how to, or some say in that decision making capability. Okay. Also the piece around compensation. So
yeah, like it's not okay to have your employees work and work and work and work and have them waiting for checks for like a month, or not pay them in gift cards, or like, I don't know.
It's real work.
Yeah,
It should
it's
compensated.
I do the
for
same.
properly.
I do the same job as my boss when they do outreach.
Right.
So I should get paid just like them.
And let's be honest, some of this work, it can't be done by people who don't use drugs. It's impossible for them to conceive of these relationships, certainly.
Mm-hmm.
another principle is in terms of diversity. So drug users or people who use drugs are all different, different perspectives, different experiences. We know, for example, in harm reduction programs, consistently across the province, they're accessed 2/3 by men, 1/3 by women. But men and women are not using drugs in significantly different amounts. So what is it about the experiences of women that's different? And we understand, we have some ideas around that. But if we don't have men and women, different ethnicities, different ages, we're only going to get some of the stories. So making sure that we're having a range of folks contribute to the discussion and design delivery.
And harm reduction, the face of harm reduction, I'm sorry to say, is so white and male. And, you know, it really needs to be more broad. Yeah.
My perspective actually is it's white and female. When I look at, I was at a meeting yesterday in Toronto around these overdoses that were happening, and it was 80% women in the room.
Oh, okay.
Maybe in different sites, it may be different, but it definitely very white. And I think that speaks to the extra layer of stigma that exists within certain ethnocultural groups around, and their experience around criminalization. We know that Indigenous folks, Black folks, Asian folks are going to be targeted much more by the criminal justice system, and it's just this extra layer of stigma that we have to work with.
And in the Indigenous community, it's like I was saying in the focus group, it's like colonization. Like they use abstinence as a way to like fight colonization and to like make a stand against it. And I think that it's a good thing, but as the generation changes, I think there should be more community specific harm reduction services.
And I understand that emphasis because of the hurt. Not just decades, centuries of hurt. And I work with more than one Native person, and like I find that if I'm walking down the street, I'm treated much differently than my buddy Johnny or Bruce. And
Oh, I felt it working.
Yeah.
Like I did a needs assessment for Indigenous folks, and even through my own agency, I felt discriminated against.
So transparency is another key principle. I need to move us along because I want to get to some practical tips too, and then make sure we have some questions in the chat. But I think, as it says here, this is the antithesis of bureaucracy, right? So when we're engaging with people who use drugs, we, again, coming back to those power dynamics, but being honest around why we're doing things the way we are doesn't mean that they're right, but having open and honest conversations, being transparent around it. One of the things we've done at the Ontario Harm Reduction Network is, for example, just being transparent around the fact that people might need to use drugs when they're in our workshops or in our events, and being open and having people feel comfortable acknowledging that to us. But also things like, if you have an issue with us as employing you or bringing you in, how do you have a complaint against us? Having a complaints process written out and spelled out, giving people documents and access to stuff, explaining things is really important. That also feeds into some accountability there. So. Yes, we're working with people who use drugs. You're going to probably have to be a little more flexible in terms of if people show up on time or maybe don't quite understand how things work. So you may need to be a little more flexible. Doesn't mean people still shouldn't be accountable for their actions. So, for example, again, we know that people may be using drugs during our work. They still need to be present. Right, so they can't go off into the bathroom, use their drugs, and then come back and not able to participate. So they need, people need to be accountable on at both ends. Shared decision-making power. I think we've touched on that one already. Increased capacity. Again, as I said earlier, this is around increasing the capacity of agencies, but also let's build people who use drugs capacity. So that might mean having training sessions. Giving them skills development of some sort, maybe providing them with internet access. People may not have internet access or a phone even. So these are things that increase people's capacity to do stuff. You want to touch on something there, actually?
I think it's important if the person is the person that's the harm reduction worker or the peer worker, what have you, the drug user, can feel they can be open and honest about their drug use too. I mean, it's take a bit of courage, of course, but also, and to let your needs be known to your coordinator.
Right, and it can help us work better with folks. So, for example, if someone's open and honest about the fact that they're using drugs and maybe they need to go to the clinic in the morning to pick up their methadone, and that's why they can't make a 9 o'clock meeting, right? So if they weren't able to be open and honest about that with us, we might be wondering, well, where the hell are they? Or it might be that they're nodding off during a meeting, or just sitting there with their eyes closed because they're feeling it a little too much today. So we now have a better understanding. I just noticed that there's Michelle has raised their hand there. Michelle, unfortunately, we can't get folks onto the phone. I'm not sure if you're just playing around with the system or if you wanted to get in with a comment. But Michelle, you can either type a comment or question in the discussion pod, or if you want to message Kim or Christian the question privately, you can do that too. So here's another resource. Again, I think this one was, again, based on a lot of the work that Rafi had originally done. This is more for an international audience and thinking about employing people who use drugs in terms of HIV and Hep C work. Just another good one to be aware of. Within that, and unfortunately, it may be hard to read this, but within there they talk about how this pyramid of involvement. And very often, a lot of agencies have involved people who use drugs as part of their target audience, or maybe helping inform some of the messaging within agencies. But if you really are doing and taking these principles at their heart, you really need people involved right from the top down. So, does your board of directors include people who use drugs? Or do you have an advisory committee to help the board inform the decisions of the organizations? Or do you have people who use drugs reflected in the management of agencies? And then all the way right down through to actual programs and delivery. There's lots of different ways of involving people. There's been historically a lot of tokenism or just little things where we give people gift cards to help put stuff together or volunteer their time. But there's lots of other ways. So it could be employing people in actual jobs. It could be you've been involved in terms of research projects, helping design research or actually facilitating research.
Oh yeah, right. I've been involved in all aspects of the research process.
Right. Research drives our work. It helps us broaden our scope of work.
And then you've sat on things like the drug strategies, where you've helped inform at a policy level what's going on. So we need to think creatively as agencies, not just always the services that we're doing, but broader systems work that people who use drugs could be involved with.
Public health comes regularly to our peer advisory panel meetings, and it's been really helpful, I think, for them as well as us to have that information exchange. And so we can see what they're doing on the strategy, and then they can ask us all the things they need to inform the strategy. So
now, I think particularly within the public health sphere, there are a lot of systems limitations and institutional ways of thinking that prohibit certain types of work being done. It may be then we need to think creatively is, can we support groups of people who use drugs, or maybe help networks of people who use drugs to do stuff? If we're not able to do certain things, are there ways of supporting again, networks or groups of people who use drugs? So that would be another thing to be thinking about, is maybe we can't be doing, as organizations, we can't be doing certain things, but we could be supporting other folks to do it. So
we're great at mobilizing.
Right?
And we have harm reduction drug user advocacy groups. In Toronto here, we have the Harm Reduction Alliance. Dual exists in Ottawa.
We're aware there's probably 10 or 11 drug user groups across the province. The problem is they are run by people who use drugs without any kind of funding or support. So as agencies, could we be thinking about little grants that we could provide folks so that it requires coordination. It requires communication. It requires some actual resources. You know, phone accounts, email accounts. It's sometimes just little simple things that really would help those groups be much more effective in doing the work. So that's another thing to be thinking about as organizations, is supporting networks and groups of people as well.
That's what we're having issues with on the Peel Drug Users Network group, is that whole funding aspect.
So folks on the webinar from across Ontario, so Peel region is just west of Toronto. It's more of a sort of not suburban, but not fully urban town outside of Toronto, sub area of Toronto. How many folks are part of that Peel Drug Users Network now?
I think like 500 or something.
500 and 200 plus active members,
Yeah.
all being coordinated by one person on their own time.
Yes.
So if some of those local agencies could pitch together and provide some supports, that would be an amazing way to support these kinds of efforts. Okay. I want to move us along to some of the more practical pieces to think about. We just have 20 minutes left here on the webinar. So again, here's another resource. I said this is a basic webinar and an introduction to some of the key principles and other resources. So this is, again, BC has done a lot of stuff around this, but if you haven't seen the website towardtheheart.com, I encourage you to look up that website. Tons of amazing resources. And again, another one for download in the box there. Just wanted to pull out some of the, just to finish off some, I think we've got 4 or 5 slides here around the do's and don'ts. So if you are engaging people who use drugs, this comes from people who use drugs. So these are the do's and the don'ts. And I'm not going to go through each of these, but maybe picking a couple, or Ashley or Pete, if you see ones that really speak to you, maybe just touch on those. But for example, as we said before, invite several people, not just one person.
Yeah, that's often the issue that I face when I go to strategy meetings and stuff, is I'm like
The voice.
the only drug user. And to be honest, I'm a lot more privileged than a lot of people who use drugs. So
It's also a lot of responsibility to put on. The weight of the entire drug using community is now on your shoulders.
on our panel, at the beginning, people didn't have they didn't feel like they had a voice because they're so used to being stigmatized. And I found myself being the only one to speak up, and slowly now that's changing because people found a voice, but like it was hard at first. So
I make it a point to bring somebody, not all the time, but often, to meetings with me. And I rarely do a workshop on my own. I always want to have somebody else, somebody else's voice. And also I'd like to recruit people into harm reduction. Not unlike I was recruited. So
We've talked about this, but making sure we have people who are actively using drugs. So very often, again, it's been people that are just practicing abstinence now. So we really want to change that.
the last one about giving the information about what the meeting is about or the role or whatnot, like it's very important to be very clear about what their role is, what the goal of the project is, and how it's funded, and your policies and procedures. That's very important, because if someone doesn't know all those things, it can be hard to do the work and do it accurately.
And I think in a couple more slides, we have some other very practical tips in terms of facilitating meetings. So we'll come back to talk more about meetings. Okay. Here we go. So how we as professionals or social workers or nurses within agencies are used to doing stuff is unfamiliar to many folks. This might be the first time someone's come and sat at a table with 20 people and felt they may feel very isolated, very alone, very scared as to how to speak. You talked about people not being able to speak up, just being intimidated.
Mm-hmm.
You can think about the intimidation then of having a police officer in the room when you're someone that's been criminalized for your drug use. So I think being very transparent too in terms of who's going to be at the meetings and how they're going to work and how long they're going to be, right? What else is in here? Flexibility in meeting style. So, for example, I'm involved with a project next week where the meeting's going to be at 6 o'clock in the evening because that's when we can actually meet with the people who use drugs. That they're not going to be able to meet during the day, so we're having that meeting in the evening. Right? So being flexible around that kind of stuff, and being very mindful of the power dynamics within meetings.
And the length of meetings, like people who use drugs because of certain things, like sometimes we can't sit for like 8 hours for training or whatever, so.
We typically, in most of that, this is a stereotype, but many people who use drugs are smokers, and you might need to build in more smoke breaks, or
Yes.
just have 30, 45-minute segments and then take a break in the meeting and then come back. So things aren't going to always be done the way they normally are. Another big thing is around how you're communicating with people. Not everyone has access to email or phone. Or if you're accepting resumes for jobs, not everyone has access to a computer. So there was a research project I was involved with recently where they accepted handwritten resumes. Right? So you really need to think outside the box and not get stuck in the way things that have always been done.
And I think, and also be aware of people's income. I work with a lot of people who are on assistance, and they just don't have the wherewithal to to pay for their transportation, perhaps, or
So that feeds well into this slide
Yeah,
here now. Right?
or have a wide range of a wardrobe to wear, and it's important that we're aware of people's poverty
It
issues.
can be hard to
Yeah.
like go to a group of people and you haven't slept all night or you've been outside and like you feel gross, you haven't showered, like trust me, I've felt pretty
Yeah.
nasty going into some of these meetings.
I was homeless when I started, and I think, and it was a struggle. I was going from church basement or a shelter to get to a harm reduction gig, and I was used to having a really rigorous, strict schedule. When I was paramedic, obviously, and other work, but I think it's best to just ask people what their needs are, because a lot of people are embarrassed about their circumstances, right? Yeah.
And not just asking, but also then offering.
Yeah.
Things.
Yeah.
People still may be afraid to say,
Yeah.
I can't actually get there.
Yeah.
So I'm just recognizing the time. We only have about 10 minutes left on the webinar. So I want to just check with folks on the participants of the webinar. Are there any specific questions people have for Natalie and Peter right now? If you could start typing those into the chat. Or if there are other points that you'd like us to address. So please do that right now. Let me just see if we had another slide here. Privacy information again, yeah. So this is one of the things that we've done. People might not want to be identified with their real name. So offering people, could you use an alias in a meeting? It doesn't have, you might, for the sake of issuing money or checks, you might need to know their legal name, but it doesn't mean to say that's the name they have to use in the meeting, right? So respecting privacy around that. I think this becomes more difficult in the context of Ontario. Much of the work we do around the province in smaller towns, confidentiality is a lot harder to maintain.
Yes.
Right? So trying to be discreet with folks maybe. Sometimes it's about not having the meeting within your agency because just coming in the door outs people. So could you have meetings in neutral places? Or interviewing people for jobs too. That was another practical thing. Maybe people feel very intimidated coming into a big boardroom within say a fancy-looking health unit. Can you just go meet them at Tim Hortons and have a chat there in the community?
Yeah.
Low-key settings.
Low-key settings. So, so someone here is saying we have a tent city behind a large store in our area. There's theft and drug use and poverty. How can we help? It's a very broad.
Is this small town Ontario or medium-sized town? Or?
Karen typed the question. Let's see what Karen. What kind of small town? So
Yeah.
Ask them. Go introduce yourself and just be their friend at first and strike up a conversation and see if there's anything they need. Maybe some food or blankets, stuff that they might need.
Be upfront, I think, just about your purpose of your visit.
Yeah.
Not like, we're we've got you on camera and surrounding.
But I think also when going in, I'll never forget. I was sitting in a injection site one day, and there were some folks from another community that were in town, wanted to come visit, and these were also health and social workers from another community, many of them working in the public health. But they came in, and you could just immediately tell that they didn't fit in based on the way they were dressed. You know, one woman was wearing high heels. So these are practical things to be thinking about. If you're coming in and wanting to connect with people in the community, be mindful of how you look, maybe. It may, you know, walking into an injection site in high heels and with your fancy bags, people aren't going to relate to you, or they're going to get their guard up maybe and wonder who you are.
And we're well aware of how ostracized and I dare say even blamed and vilified for many things too, right? And
we haven't really, I mean, this was just a very basic introduction, so we have not dug deep into things, but maybe just touch on, maybe, is there anything around boundary issues you want to talk about, or training things?
I think sometimes it's unfortunate that the relationships that we have, like, we will have friends and we'll bring them in as clients, and sometimes that's used against us, that we don't have proper boundaries because, you know, we've used drugs with that person in the past, so now we can't provide them services as their outreach worker because of that. Meanwhile, we're the reason why they're a client in the first place. So I think some of those issues around boundaries.
Sorry, this is, so Blaine is asking a question here, and I wonder around what training would you like to have had when you first started out in a payroll? Did you get any kind of training, or were there discussions of policies? Or
I got all kinds of harm reduction trainings. I got harm reduction 101. I got first aid. We're doing mental health first aid right now, and they've actually accommodated us. They've made it 5 sessions instead of 2, so that they're shorter and so that people who use drugs can attend them and actually be present.
Because the original training was 2
8-hour
sessions.
days.
It just didn't work. So
No.
they've listened to that, and now they've broken it into small sessions.
We did first aid and we couldn't get that accommodation, and it was apparent that we needed to do the accommodated way. So, but yeah, first aid, especially when dealing with people who use drugs because of the overdose aspect, overdose prevention, naloxone training, stuff like that.
I think for me, I was fortunate. I had a handful of people who were mentors and who really guided me well. For me, I took an active listening course, and then I took a motivational interviewing course. And I thought I had it all together when I came to harm reduction, but I was naive a lot. How to really conduct outreach. I was trying to do too much in too little of time. And although I was driven and eager, I had kind of reined things in. And I think just to give people the confidence, because our work is largely communicating. It's about listening and giving people direction and giving people information and referrals if they are open to that. But and also small talk. The importance of small talk is small talk, because that trust can be lost really quickly if the wrong thing is said at the wrong time with some people. And I've lived in small town Ontario. I know how much how more people are perhaps more vulnerable. Yeah.
I think another piece of this, and this has become just even more and more apparent every day as we're going through all the overdoses that we're seeing, but it's the piece around trauma, and giving people space. A lot of these peer roles are contract positions that don't get benefits. But you're working, so there's an example of someone I know in Toronto, and there was someone we connected with and helped at one of our focus groups around some of the work we're doing, but there's someone working in an overdose prevention site They intimately know the clients there.
Mhm.
They actually had a relationship with one of the clients. That client died from an overdose, and this worker was not entitled to any bereavement leave and had to keep coming into work. Or if they took the time off, it was now unpaid, and now they're not going to be able to pay their rent. So an example of the complexities of the work, but also how we don't always support folks doing the work. It's in terms of treating them as staff. So really starting to think in terms of how else can we support people. It's not just about a paycheck, but it's all sorts of other supports people might need, and particularly around the whole loss and grief piece. It's very complex these days.
I'm going to another memorial tomorrow morning, and I've lost count of the people I've lost, people who I've known intimately and I've really had close working relationships with, clients, friends.
So someone's asking, how can we build trust when working with new peers as someone who doesn't have lived experience?
That's a tough one. Don't try to act like you're one of them, because that is one thing that, like, it's one thing that we've experienced in our panel is, like, we can easily tell an outsider, so don't try to, like, act like something you're not, or
So just being upfront and honest that
Yeah.
you don't have that experience.
Yeah.
This is why
Yeah.
I
just be yourself, honestly.
Yeah.
Because honestly, we just, as drug users, we just want real. Like, we just want to deal with real people who are kind and nice.
I often ask why people are drawn to this work. Sometimes I don't really get a reason, but I think more often than not, there is a reason behind people being drawn to this work who are not from our world. Yeah.
I think it's also just having patience, recognizing what you don't know. And then I just want to finish off on this slide here because we just have a couple minutes. So just in summarizing all of this, I think it's about this kind of work is very challenging. It's a different way of thinking for some folks. So you need to be flexible, thinking outside the box. The way things have done is going to change. The way we've historically done things is going to change. From a programming point of view, you really need to rethink and probably reflect on your budgets and funding that may need adjusting so that we can actually start supporting this work in a real way. You might need to be developing policies. So the resources we've got and given you there, and you can download, have examples of policies, but you might need to actually develop some policies around drug use at work, or what your overdose prevention protocols are, or what some of these boundary issues are, how you're doing debriefing or discipline stuff when those challenges come up. A big one is around training for non-drug using staff. So you're nodding your head around that.
Frontline workers.
Yeah, I think that's important.
Yeah. So we've seen this in, I can think of a community health center in Northern Ontario where they implemented an overdose prevention site. But the workers within the health center were understanding of it, but it started bumping up against some of their values and attitudes. So some work with the non-drug using staff to understand why we're doing this and some of the challenges and how to address some of that. We talked a lot about shifting the way meetings and interviews are being conducted. Ongoing staff check-ins and debriefings and development, so important. Just constantly reviewing and adapting what isn't working, and then just start connecting with agencies that are doing good work already. So we know there's many of those. If this is particular interest to you or this is new stuff, follow up with us after the fact. I'm just going to leave you with, those are Ashley and Peter's contact info. We'll send this out after, but they both expressed an interest and willingness if you want to reach out to them or have opportunities for them. Please connect with them. And then before you all leave, if you could just click on this quick survey, it really helps inform our work as to what works well, what doesn't. So we do really value that feedback. So please just spend 5 minutes giving us some feedback on this. If you would like a certificate, you can also request a certificate of completion for the webinar. And then that's how to connect with just the Ontario Harm Reduction Network. So again, please follow up with that after the fact. You'll be hearing from Christian or Kim or myself in the next week or so. We'll be sending out all these resources. We'll send a recording of the webinar. And I just want to say thanks to Ashley and Peter. It's been good working with you this time, and hopefully we'll do some more work.
I'm just reading Moss Park stand up.
I know.
All right, so sorry it was short. I think we could have spent a lot longer on this, but this again was a very brief overview, some really good resources there, and please connect with us again after if you want to talk more about this. Thanks. Should we end the recording?
Well, that was pretty damn good.
You want me to